This will be an introduction to capnography. The idea will be to get you just familiar with some of the particulars of 12 lead, especially the normal values, what's abnormal, and just a basic introduction on how to read some of the waveforms. So we'll look briefly at review of ventilation. This is recorded for EMS initial education classes, so it won't go into a whole lot of that. When I do this for CE, I typically spend a little bit more time on the ventilation physiology, which I'm not going to do with this recording. I will talk about, though, capnography, how it works, and ventilation as a vital sign. And then that's when I start getting into normal capnography waves and the values and how you can apply it to your patients. So just some review of the anatomy. I'm not going to go into too much, but just remember that the airway is a conduit to the alveoli. Just another view of the airway. Um, the important point is that the air gets to the alveoli, and that's where we have gas exchange, and that's going to be very important when we start talking about capnography, because the CO2 diffuses from the bloodstream into the alveoli, and that is where you exhale it, and that's where we can measure. Just another picture of the sponge, the way the lungs look. Remember that ventilation is different from respiration. Ventilation is the mechanical process of moving air in and out of the lungs. Remember that we do that with a negative pressure ventilation normally. Unless we're being ventilated, we have negative pressure ventilation. So our lungs expand, our chest wall expands, our diaphragm drops. We increase the volume of the chest cavity, which decreases the pressure and air flows in. And that's Boyle's law, and that's what this picture shows, that when we have a closed system like the chest cavity, when we increase the volume, the pressure goes down. When we decrease the pressure, when we decrease the volume, the pressure goes up. So that's how we exhale. And of course, all that's passively as everything recoils back to its original position. So what's the difference between oxygenation and ventilation? Ventilation is the mechanical process of air moving in and out. So oxygenation is just the ability to load the blood with oxygen. And then respiration, as we mentioned, that's the gas exchange in the capillary. And remember, we have two types. We have the external respiration, which is also known as alveolar respiration, and that's when the gas exchange takes place in the alveoli. And then we have internal or cellular respiration. That's where we have gas exchange at the capillary in the tissues. Remember that when we're talking about ventilation, that we have minute ventilation equals respiratory rate times the tidal volume, but we need to adjust for dead space. And because the gas exchange does not take place in the trachea, for example, so the air in the trachea is not participating in gas exchange. So when we're talking about ventilating, we're really talking about the alveolar ventilation. That's the important point that we need to consider. So when we're looking at somebody who's breathing, we need to not only look at rate or the respiratory rate, but we need to look at their tidal volume. If it's not a significant tidal volume, remember the dead space, then they're really not ventilating effectively. I believe this picture just shows or illustrates the dead space. Another picture where we're talking about the alveoli and the gas exchange, and it's just another picture to show the capillaries around the alveoli, and as blood flows through those capillaries, that's where we have gas exchange. We have fresh oxygen diffusing into the blood, and we have carbon dioxide offloading, diffusing into the alveoli. And the same thing in this picture, we have the carbon dioxide is coming from the body. And just another picture to show, or actually a animation to show the blood going past and you see all this carbon dioxide. There's the fresh oxygen that's going to diffuse over into the blood, and then you have the carbon dioxide, which is going to diffuse into the alveoli, at which point the patient exhales, or the person exhales, and that carbon dioxide leaves the alveoli and then leaves the lungs, and that's where we measure it at the end of the breath. Same thing going on here. This is what happens if we don't ventilate. We don't clear out that alveoli. Well, more and more carbon dioxide is going to um, diffuse over into the alveoli until it gets to a point where it doesn't diffuse very fast. So if there's a lot of carbon dioxide in that alveoli, it's going to slow down diffusion from the blood into the alveoli. And the key part here is that the blood gets hypercarbic. So when that patient actually exhales, so if they're breathing really slow and shallow and they finally exhale, that carbon dioxide that we measure is going to be really high, and then we can assume that the carbon dioxide in their blood is also high. Just recall that oxygen is mostly transported in the hemoglobin, but carbon dioxide is a little bit different. 70% actually mixes with water and creates bicarbonate, and some does attach to the hemoglobin, and a very little, 7%, is dissolved in the plasma like carbonated soda. So CO2 and oxygen, just kind of complete the whole cycle. Oxygen is inhaled, arrives at the alveoli. Oxygen diffuses across the alveoli into the bloodstream, where it eventually binds to hemoglobin. Oxygen is transported to the systemic capillaries, where it diffuses out of the blood into the tissues. So oxygen is then used in the process of making energy, which we refer to as ATP. We just think of that as energy. So anything the cell does usually requires ATP to work. So the cell makes a whole lot of that so they can do things like crawl and things like that, and maybe even metabolize certain toxins or whatever, or for muscle, we use ATP that muscle to contract. So we need to make a lot of that ATP, and oxygen is actually used in the process of making that ATP. The cells use oxygen and sugar to form ATP, and as we said, it performs almost every cellular function that requires energy. As a byproduct of this process, carbon dioxide is released. So as we chop up that sugar molecule, we're going to release the carbon, and we release it as carbon dioxide. Carbon dioxide diffuses from the cells into the capillaries, into the blood, where carbon dioxide is transported back to the lungs, where it diffuses from the blood into the alveoli. And that's just another picture of everything we said, where from the lung, oxygen goes to the cells, used in metabolism. As a byproduct of metabolism, we get carbon dioxide, which is transported back to the lungs. CO2 is then ventilated out of the lungs if we have adequate ventilation. So what happens to the carbon dioxide if there are hypoventilations, or slow or shallow, or slow and shallow ventilation? What happens to the carbon dioxide? And we've already talked about that, how the carbon dioxide builds up in the alveoli to the point where it has a hard time diffusing out of the bloodstream, so we get high carbon dioxide with hypoventilation. With hyperventilation, it's the opposite. We blow off too much carbon dioxide, so the carbon dioxide in the body actually is going to go down. And that's almost counterintuitive to what you think about. You think about, oh, if I'm breathing really fast, the machine is going to measure a whole lot of carbon dioxide because I'm breathing a lot of carbon dioxide into that machine, but it's actually it's measuring the carbon dioxide within your body, um, which has just left your body. So it's a measure of the inside of your body, not how much you're blowing out. So it's counterintuitive. Sometimes the first time you look at capnography, it's almost backwards and then what it really is. But remember that hypoventilation, low ventilation, is going to have high carbon dioxide, and hyperventilation is going to have low carbon dioxide. So, um, so the premise is if we could measure carbon dioxide, what, which we can, what do you know about your patient? Well, you know that they have an airway, and we know if they're ventilating. Well, if they're ventilating, and we also know if they're perfusing. Um, so if they're in shock, or if we're doing CPR, we can literally measure the the perfusion. So one little thing that I didn't tell you was that kapnos in Greek is smoke, and if you think about it, so what we're carbon dioxide is a byproduct of metabolism. So literally, if we can detect the smoke, there is fire. So when we're doing CPR, if we're getting good capnography or good CO2, we have not only good perfusion, but we also have metabolism occurring in your patient's cells. So how does capnography work? So basically, a sample of the air that is exhaled goes into the machine. Um, in this case, it's going to be a side or a micro stream, which the sample actually goes into the machine rather than the sensor is beams through the exhaled sample itself. Um, so the sample goes into the machine, and then it goes through a chamber where a infrared light is beamed through it, and based on and the light is detected on the other side, and based on how the light flows through that sample, the computer can figure out how much carbon dioxide is in that sample. We have several types of ability to sense carbon dioxide. We have the nasal cannula, so for patients that are not intubated or have an advanced airway, you would use one of these. You can put a non-rebreather mask or a BVM or a CPAP mask over top of them. You certainly can do that. Also have the piece that goes on the end of the advanced airway, so whether a king or an endotracheal tube in this case. But you can also use it on a BVM, and in this picture you see the BVM with the end tidal or the ET tube adapter piece between the BVM and the mask. So you can use it that way. The only problem is that you would need a really good seal and maintain that the entire time, or you'll get gas leak out of the side of the mask and you won't get a true reading. And then, yes, you can certainly use it with capnography. I'm sorry, with CPAP. You can definitely use capnography. And this another thing to note is your monitors. This is a LifePak 12 monitor, but this will apply to just about any machine that you're using. If you notice that the scale is 0 to 50. So here's the scale on the where the CO2 is detecting. So it's going to pick up the end tidal. So right here, as you can see, you're just below 30, so about 29. That is the end tidal of the measurement is 29 millimeters of mercury of carbon dioxide. And by the way, the respiratory rate is 16. But what would happen if you change this scale? So instead of 0 to 50, now we want to change it to 0 to 100. The result is smaller boxes. So essentially the same thing. This one's 30 instead of 29, but essentially the same thing, which is running right here. So this is from 0 to 100. And you'll notice that it's smaller boxes, which is not a big deal. The number is the same. The shape of the boxes, although smaller, are the same. But if you would just glance at those small boxes, you might think that the patient is breathing really fast. Without looking at the number, you might say, "Oh, they're breathing really fast and they're hyperventilating." But look at the number and look at your scale. I bring this up because here's 50. If your patient is running, let's say their CO2 is varying between 58 and I'm sorry, 48 and 52, and you have it set to auto scale, when the CO2 is 48, it's going to change back from 0 to 50, that scale from 0 to 50. And you're going to see nice, big, huge boxes. And then next thing you know, or maybe you don't realize it, the CO2 has gone up briefly to 52, and it's going to auto zero, and it's going to be the scale is going to be 0 to 100. And next thing you know, you're going to see a huge change in your boxes. All of a sudden, now you have these small boxes where you had these large boxes before. So just be careful. You can actually set the scale to 0 to 100 if you run into that problem where that patient is breathing between, kind of alternating and making the scale go between the 50 scale or the 100 scale. So just pay attention to that. If you see all of a sudden large boxes and small boxes, or small boxes and very large boxes, look at your scale. So normal values are between 35 and 45. So a value of 30 means that the patient is hyperventilating. They're blowing off too much carbon dioxide. A value of 50 means they're retaining CO2. They're not ventilating effectively. And you can do this demonstration, or you can do this experiment the next time you're at your agency and you have a few minutes. You can hook yourself up to capnography and SpO2. And the deal is try to just look at the values without doing anything. So breathe normally for a minute, and you should get a CO2 between 35 and 45, and you should get an SpO2 of 95 or better. But let's say then to do this experiment, breathe rapidly for 30 seconds. What do you think happens to the capnography? Actually decreases, and the SpO2 may increase a little bit or may stay the same. But try to hold your breath and hold your breath for 1 minute and then breathe. And your next breath, right after you held your breath for a minute, or really as long as you can if you can't go a whole minute. But the next value for your capnography, remember, you've held on to all that carbon dioxide for a while. And by the way, I would do this. I would wait until after you've hyperventilated. I would wait about 5 or 10 minutes before you do the hold your breath thing, or you're just going to be back to normal. So hold your breath for 1 minute after you've waited about 5 minutes, and the next breath is going to be very high in carbon dioxide. But what's going to happen to your SpO2, and that's really the big value of capnography. You can't change your SpO2. It might fluctuate one or two, up or down a percentage, but you're not going to significantly change your SpO2. You're going to go unconscious before your SpO2 changes. You can't consciously, under normal conditions, change your SpO2. But the thing though, is if you hold your breath for a minute, the capnography is going to alarm at 30 seconds. So you're going to see capnography go quickly down to 0, and your respiratory rate quickly to 0. So it's a really good tool for monitoring a patient who's sedated or altered mental, who you're worried that might stop breathing. Put them on capnography. If you just have them on SpO2 and you do see a decrease in the SpO2, that means it's been several minutes that they haven't been breathing adequately. So capnography, though, the 30 seconds is going to alarm and tell you this patient's not breathing. And honestly, sometimes it's hard to see that in the back of the ambulance. That's really a great value for capnography, is that um, you can monitor their ventilations um, better than you can with just your eyeballs, and certainly better than with SpO2. So what do the waves mean? If you Again, it's a little counterintuitive, especially if you had EKG training, where the big spike is really the heart squeezing. So it's the opposite. Remember that we exhale passively, or we should be exhaling passively. So the big bump or the big box is really when the lungs and everything are relaxing, going back to normal, when that air is flowing out of our lungs. So the very first line there, A, is baseline, so that should be 0. And then the patient starts to take a breath. And remember, there's no increased carbon dioxide in the air in the mouth and the dead space. In the trachea, all that, there's no carbon dioxide increase because we don't have gas exchange. So all that air has to come out first. And that's why you see a sudden increase from baseline to a very sharp climb. And that's we're getting rid of all the dead space, and then we quickly now are getting rid of that carbon dioxide in the alveoli. So you see a sudden and dramatic increase in carbon dioxide. Finally, all that carbon dioxide comes out, and we kind of hit a plateau. It does increase a little bit, and that's okay. So if it's not a level box, that's okay. In fact, most of them aren't quite level. But at that very end point, the end of that tidal volume, that's where we calculate the we calculate the end tidal right there. So that's where we calculate the end tidal CO2, right there at that end of the box. And then we breathe, fresh air comes in, and that's where the line goes quickly back to baseline. So again, this is normal. We have the dead space. We have the alveolar gases finally making it to the sensor, and it plateaus, and then we have inhale going right quickly back to 0. All right, so if the patient breathes fast and or deep, the CO2 level goes down. If the patient breathes slow and or shallow, remember the carbon dioxide goes up. So hypoventilation equals hypercarbia. Hyperventilation equals hypocarbia. I can't stress that enough. This is probably one of the most difficult parts when you're learning capnography, is it's the opposite of what you think. If they're breathing shallow, they're going to have a buildup of carbon dioxide. If they're breathing too fast, their carbon dioxide is going to go low, and they're going to feel funny. They're going to feel tingling on their face and the carpal pedal spasms. So this is a patient that we had with, if you notice, he is breathing 31 times a minute. His CO2 is very high, 54. And if you notice, there's the 0. The scale is a 100 scale. And his SpO2 is 94. So without even knowing anything about it, he's breathing 31 times a minute. But remember, ventilation is not just rate, it's also depth. So he's breathing fast, but he's breathing very shallow. And this patient actually had several rib fractures that he was in pain, so he didn't want to breathe very fast. So as a result, his carbon dioxide would went up, and his oxygen was low. So we just gave him some oxygen. At this point, that high carbon dioxide, that's not good, but he wouldn't tolerate CPAP or BVM, especially because that just hurt his rib cage. So we just had to manage him the best we could. All right, causes of hypoventilation. carbia or the carbon dioxide decreasing, the patient's hyperventilating, or you are bagging too fast, or a PE. Remember that if the blood can't get to the alveoli to exchange gases, we're going to have a decrease in carbon dioxide. There's another way to interpret that. We could be hyperventilating, but in the scenario two, uh, the patient is breathing so tight. She was so full of fluid that we didn't get any carbon dioxide return. So you can see how low this is. So the patient, she was breathing 44 times a minute. Um, However, we weren't getting any capnography. We weren't getting any gas back to our machine. So she was so tight. Um, and so think about, it's not just what the number is. Look at your patient. Are they just breathing really fast and deep, or breathing really fast, or is your patient breathing really fast, really struggling to breathe, accessory muscles, full of fluid, to where there's just zero carbon dioxide coming back to our sensor? So, and this is a case where we don't know, because we have to look at our patient. Is this hyperventilating, or are they just not moving any air? And the answer is you can't tell by the box. You have to look at your patient. But this one is pretty dry, pretty cut and dry. If you have big boxes, you have hypoventilation. That's what it is. So narcotic overdose, CNS depression, sedation. You gave a little too much Versed, or your medic gave a little too much Versed, whatever, and the patient's now kind of not remembering to breathe as effectively. So don't equate high boxes with deep breathing. It is the opposite. And then you see the wave, and then nothing. If you notice, the SpO2 is the same. He still has a pulse, but he just stopped breathing. The next is the shark fins, and that's where we equate this with bronchospasms. And you can see a real example there on the strip below. So what do the waves mean? Remember that the carbon dioxide is filling up the alveoli as blood passes by between your breath, and then the dead space has to come out, and then because we have bronchospasms, not all the alveoli get out at the same time, or not all the air in the alveoli get out at the same time. So we have a little bit of gas mixing. So that's why we have this small plateau. So it takes longer for this carbon dioxide to get out of the alveoli. So we end up having this slant now, as we have slower carbon dioxide getting out of the alveoli because of all that clamped bronchioles. So that's what the shark fin means. Partial obstruction, ET tube obstruction, or bronchospasms. This is another type of wave, and I haven't seen this with the newer monitors, but you may see it. Remember that those nasal cannula capnography sensors, you can sometimes flow oxygen in with it as you're sensing. And this was a patient that I was transporting that had he was on 4 liters of oxygen, and if you notice, this patient's carbon waveform changed to what I call a chair wave, or an Idaho wave, but I like the chair waves, where it looks like a chair. And I thought, what the heck is going on there? CO2 was still, the end tidal was still detecting it right here, so that was fine. So I was still getting about the same number, but I had these weird looking waves. And what I figured out by taking him off of 4 liters, I put it back on 2, it turned back to a normal box waveform. But when I cranked it up to 4, I saw these little the chair waves again. And so what I figured, it was gas mixing, where the oxygen was mixing with the carbon dioxide, so I was getting a weird looking wave. In the end, it didn't really change anything because the end tidal still detected at the top wave rather than here. So I was still getting the reading. If I wanted to check, all I have to do is just turn off my oxygen for a second, and then it goes back, and then I can crank them back up. So clinical applications would be any patient less than alert. If your patient gets any sedating drugs like fentanyl, morphine, your benzos for seizures or sedation, whatever, they should get capnography. Any patient that has difficulty breathing, because it tells you so much. Any patient that you are ventilating, or they're on CPAP, or you have to do an advanced airway, they should definitely get capnography. And any patient in cardiac arrest, because that can tell you your, not only do you have an airway, but it also tells you how well you're doing CPR. And just any patient that you're worried will decompensate. All right, so this is an intubated patient, and right now it's a standard of care. There's just really no excuse not to have capnography when you have an advanced airway in place, especially intubated. Um, and so if you have the correct placement, the capnograph should show a nice box waveform. However, there's the esophageal placement. You won't see any waveform. Uh, What about carbonated beverages? Remember that we get these nice waveforms based on the carbon dioxide coming out of the alveoli. So if you do have a patient, and let's say hypothetically you did have a patient that arrested right after they drank a soda, and you got there and you stuck the tube in the belly rather than the trachea, and you had all these, you did have some sort of CO2. The point is that you probably wouldn't have a nice box waveform. However, and you can test this. You can actually take one of your capnography sensors and put it over a soda and kind of give it a shake, and you can see what that waveform would look like. It's not. It's just all over the place. It looks like where you can't get a pleth on your SpO2. There's no box waveform. So even if that's true that you could detect carbonated beverages, you're not going to get a waveform. There we go, tube dislodgement. So you can see the tube came out of the trachea, and now we're not getting CO2 anymore. No box waveform. How about right mainstem intubation? And the point here is that no, it won't show a right uh, a right mainstem intubation. So you still have to listen to the breath sounds, and that's just good clinical practice anyway. So listen. So in addition to capnography, you see misting of the tube. You still need to listen to both sides. A couple of key points is to hit print after you intubate, um, or use a advanced airway, and then each time you move the patient, hit print, and that way you have a strip printed to show that you are in the correct place and still in the correct place. Or you can hit on the LifePak 12s at least, or the LifePak 15s. You can hit intubation, and it'll mark it as an event, and then that will automatically save the CO2 at that moment. Also, generic will also work. Um, Remember, low perfusion states, the waveform will be small. Small boxes means small CO2 return. You start to see these cleft waves in an intubated patient. That means they are becoming less sedated and starting to breathe over the tube. So um, have a plan to manage that, and you may need to resedate them or sedate them. Maybe it's a cardiac arrest that you got return of spontaneous circulation, and they're waking up from their brain being hypoxic, and maybe you need to start thinking about sedating them if to risk losing your airway. All right, trends. This is also a nice get out of jail card because it shows you every one of these bars is 30 seconds. So there's a minute. Two of these is a minute. So this might show you 30 minutes. Or if you got 15 box or 60 boxes, that's 30 minutes. And so if you see in this patient, they maintained the CO2 at the appropriate level the entire transport. Also, cardiac arrest, not only measuring your great CPR, but also you see a spike in CO2 when you're doing compressions. That means that your patient had a return of spontaneous circulation. Remember, during compressions, capnography is a good indicator of effectiveness of compressions. In American Heart, if you're doing good compressions, you're not over ventilating that patient and blowing off too much carbon dioxide. So your good compressions, good ventilation, but your end tidal remains below 10 for a period of 15 to 20 minutes. That is a non-viable patient because you're moving blood around, you're ventilating correctly. They just have no metabolism. So even though you have good perfusion, good compressions, that's a non-viable patient. A spike in CO2 is ROSC, and I would finish your cycle of CPR. So in this scenario, your patient is having very low ventilation. They're actually hypoventilating even though the boxes are small. So remember, look at your patient. Also, if you notice, there's a lot of artifact with the EKG, and in this situation, the patient's actually having a seizure. So we get a lot of muscular artifact with the seizure, and then you can see that the patient is not really ventilating very effectively. So what do we need to do for this patient? We need to assist their ventilation as best we can while they're having a seizure. At the very least, protect them. So another benefit of capnography is it doesn't have artifact like SpO2 and EKGs. This is another scenario where you have given yourself or given your patient benzos, or maybe the medic has given the patient benzos, and you see very hypo ventilation with these very large boxes. Remember, big boxes do not mean deep breathing. It's the opposite. So this could be a patient between seizures or postictal. Maybe we need to ventilate them a little bit, or maybe we gave them benzos and now they're sedated. In any case, we need to ventilate that patient. Here's a scenario. We have a patient that has difficulty breathing, and this is probably one of your more complex situations. A 68-year-old female with difficulty breathing, a history of heart attack, coronary artery disease, CHF, and COPD. So with our differentials on COPD or on difficulty breathing, of course this could be COPD, this could be CHF. We get there, she's working really hard to breathe, she's got accessory muscle use, so she's not ventilating very well. The problem is, why is she not ventilating? Is this a COPD exacerbation that's she's bronchospasms with in having a hard time breathing that way, or is she having some CHF issues where she's got some congestion, she's got some fluid buildup, and honestly, sometimes it's very hard to hear that difference with the stethoscope. So you put her on capnography, and this is what you see. And so the question is the difficulty breathing caused by COPD, or is it caused by CHF? And remember, if it's COPD exacerbation, we would expect bronchospasms. And we know what bronchospasms look like with a capnography, with a capnogram. We would have shark fin, and we don't have that now. So now we know that it's probably not COPD, it's probably CHF. And this is important because about 50% of CHF patients are inappropriately given albuterol. Remember that that is a adrenaline agonist, so it's not without its side effects. So if you have a patient with severe CHF and you give them maybe something to stimulate their heart more, you could potentially make that worse. So this is a good tool to augment your clinical assessment, and we don't see any shark fins. They don't have bronchospasms. I'm going to hold off on the albuterol and see if I can alleviate the symptoms with nitro and CPAP, and maybe that might be the best course of treatment rather than also giving her albuterol. All right, another scenario, we have a 68-year-old female who fell. She was standing on a chair to change a light bulb. She fell to the ground. She had pain in the right elbow and shoulder. She is a smoker times 40 years. She's got COPD. So you do your great BLS. You splint the arm. There's her vital signs, so not bad. The only issue, which doesn't have her SpO2. Let's see if we have that in the next slide. So we've splinted her arm, so we're going to give her some pain management, or maybe a medic that's with us give her some pain medicine. So we give her some fentanyl and some Zofran prophylactically. Since we gave a narcotic, or your medic gave a narcotic, you say, hey, I'm going to put them on capnography. Good idea. By the way, there's her SpO2, 93 to 94%, and that was on room air. And if you look after you've placed her on capnography, you notice she's also has these shark fin waves going on. So because she has those shark fins, you give her albuterol atrovent neb, and her SpO2 does remain 93%. Even though you've given her treatment, and I believe in this scenario we also gave some nasal cannula oxygen. We get to the scene, or we get to the hospital and give a report and everything, and go to get a signature for the call sheet, and the physician questions the SpO2, wondering if that little bit of fentanyl actually caused some ventilatory suppression, and to which not only do we have a before and after SpO2, but we have this documentation that she has bronchospasm, she has COPD, so it fits this different picture. So the narcotic was appropriate, and we also had this a bronchospasm issue underlying that we may have missed. Quite honestly, we were there for a broken or a injured elbow. She did not complain of any difficulty breathing, so this was a win for capnography because it detected something that we may have otherwise not detected, and avoided a question from the physician that maybe the narcotic caused the decrease in SpO2, but when we were able to show, no, it's her COPD, it was a hot day, etc. So you see bronchospasm, hey, you can treat that. Okay, in this scenario, you have a 22-year-old with altered mental status. Been sick for about a week. She's got abdominal pain, polyuria, polydipsia, so that is urinating a lot, drinking a lot, very thirsty. This morning, she's just not responding appropriately. Skin is warm and dry, tachycardic, and she's breathing rapidly. Blood sugar's 500, and end tidal, we put her on capnography. End tidal was 22, and there is her waveform. So one thing to remember, this shallow boxes are not mean shallow breathing. It's the opposite. Shallow boxes means she's breathing fast and deep. At least she's breathing deeply for the shallow boxes, and we see them in quick succession, so she's breathing rapidly. And this has a name where they are breathing fast and deep, and that's Kussmaul, and we see that with DKA. And that fits that clinical picture as well. But capnography is very useful in detecting these metabolic acidosis cases because, remember, carbon dioxide is an acid, at least in the context of mixing with water. It creates an acid. So when we have some sort of metabolic acidic condition that pushes our blood to acidic, we're going to compensate by getting rid of the carbon dioxide acid. So that's where you get that Kussmaul breathing with the DKA. But we'll see that also with sepsis and also aspirin overdose. You'll see that fast, deep breathing with aspirin overdose. With sepsis, you'll see tachypnea, not necessarily Kussmaul, but the body's compensating by blowing off excess carbon dioxide to make the pH of that blood, or attempt to compensate for the pH of the blood. So end-tidal is correlated with the carbon dioxide level of the blood. Another scenario, let's use this in a trauma case. So we have a 18-year-old with a gunshot to the chest. The great thing about capnography is if you're in an environment that you can't hear very well, which the ambulances or helicopter, you're not going to be able to hear the breath sounds or at least very well. So that's why capnography is going to be such a great tool to augment your clinical assessment, because you can monitor their ventilation, you can monitor their perfusion. So in the back of the ambulance, you can't hear anything. This patient has increasing difficulty breathing and anxiety. You place them on end-tidal and you notice a trend. So it won't be as dramatic as this, where every subsequent breath you have a decrease in the level, but over time, let's say over 3 or 4 minutes, you do see this as a trend where he's breathing faster, the carbon dioxide is decreasing. So the question is the CO2 decreasing because he's hyperventilating? Well, he is starting to breathe faster. He's got some anxiety. Is he just hyperventilating because he's anxious? He's thinking about being shot in the chest, whatever. Is he decreasing the air in and out? That's probably not the case, because we're watching him breathe and he's breathing fast. Or does he have decreased perfusion? Remember, we can't necessarily. Remember that capnography also is a perfusion vital sign, because where there's smoke, there's fire. If he's got metabolism, he's got perfusion, then we're going to pick up that smoke in the lungs. So there's our 3 choices in list form. So the question is, how do we determine the difference? Well, we got to look at the entire picture. We have to go back and look at our patient. By the way, early in the scenario, his blood pressure was 120/80, and now his blood pressure is 70/40. And so the question is, he's having a hard time breathing, he's got anxiety, he's clearly trending down with his blood pressure. He is breathing faster, but my thought would be maybe his carbon dioxide is decreasing because he has a decrease in perfusion, and this is correlating with a decrease in cardiac output. So he's in shock, definitely, and this could be a hypovolemic shock. But remember, he's increasing difficulty breathing. We can't hear breath sounds, so let's go ahead and assume he might have a tension pneumothorax, and that's easy to treat. So we can definitely decompress that chest. Why didn't we get tracheal deviation in JVD? And remember that those are late signs of a tracheal deviation, so you won't see them. The real difference between a pneumothorax and a tension pneumothorax is that we got hemodynamic unstable, becomes unstable. All right, we have a TBI patient. We have a 19-year-old male with a MVC head trauma. His GCS is 8, combative. Your medic RSIs the patient. You have a student bagging the patient, and this is what his capnography looks like. And so the question is this okay? And the answer is absolutely not. This is not okay. Remember that head trauma, we do not routinely hyperventilate our patients, and this is what's going on. The student, for whatever reason, I would be too. I would be maybe a little excited and maybe bagging a little too aggressively, and this is what's going on in this case. The EMT student is just bagging too fast, so we really need to hold off and let that carbon dioxide build back up and maintain the end tidal between 35 and 45. And the reason is because that decrease in carbon dioxide, we have a head trauma, we might have increased intracranial pressure, and if that's true and we're hyperventilating the patient, as we hyperventilate, the carbon dioxide decreases, which causes cerebral vasoconstriction. So we're having a hard time getting blood to flow through that tight squeeze space, and then we cause vasoconstriction, which is going to make it worse. So no, this is not okay. We really need to back off, and we really want that between that 35 and 45 area. For documentation, just describe the box. You have a box waveform, or do you have a shark fin waveform, or something else? Report the end tidal, the number. So I normally just write normal box waveform. End tidal is whatever. Provide strips, especially if you're doing a procedure, an advanced airway procedure, especially COPD. You can show CPAP, where you can show before and after, where you're actually improving. This is just great documentation. This is another example from an internet case where you see they're so tight. They have asthma, an asthma situation where they're so tight they're not moving any air. So even though we talked about that patient is hypoventilating, they're hypoventilating to the point now where they're not getting any carbon dioxide out. And you can see these pretty profound or pretty low shark fins. Gave her treatment, and afterwards you can see much better, at least much better waveform. It's still a shark fin, and then after 2 doses you can see it's returned to that box waveform. In addition to this, I would also breath sounds. I would expect to hear diminished here. I would expect to hear wheezing everywhere here, and then here at the bottom I would expect to hear clear. Maybe some residual here and there, but look, we've given 2 treatments. We show a progression from before, after the first treatment, after the second treatment, we show an improvement. So this has been capnography for just about any provider. Can definitely benefit from this lecture, but just let me know if you have any questions, and please keep learning. There's a lot of resources out there for capnography, especially for pre-hospital capnography, ems1.com, and there's also a Capnos Academy online.